Thank you. So let me share my PowerPoint. Thank you for Data Bank. I think we are as Data Bank introduced, we are good friends because we both of us were the roommates when we stay in Seoul. So now today I'm going to talk about thermal aberration for thyroid. I majorly will focus on IFA because as we all know, for thyroid nodule, in addition to surgery, nowadays we have many different minimal invasive treatment. For most of them, I think IFA now is very mature in Taiwan because I was in Assam Medical Center in the year of 2015, about 6 years ago. After I come back from Seoul, we promote this procedure in Taiwan. And I think now in Taiwan, IFA is widely accepted for all people and the doctors. And we also have HIFU, but HIFU is just getting popular, not that common. But fortunately, because of Eco company, now we also have the microwave. Because this year, I just have my very preliminary experience to use microwave to treat thyroid nodule. In the end of my presentation, I will shortly to introduce my very preliminary experience about microwave, but I majorly still focus on thyroid IFA. I think most of us are familiar with this kind of thyroid IFA, so maybe I will focus on some case sharing. And I think all of the doctor don't like complications, so we'll talk about the complication, how to deal with the complication, and what kinds of complication we will encounter during the IFA procedure. So let's begin with the case sharing. Because I think we have to know the indication of the IFA, no matter how IFA or HIFU or a microwave, I think all of us will agree with to treat the benign symptomatic thyroid nodules. Because for this kind of patient, I think surgery is very efficient. It's very effective to treat this kind of patient. But usually, I think it's too aggressive for the patient with benign symptomatic thyroid nodule. So this kind of thermal aberration is very good for this kind of people. But now some guidelines have also mentioned the recurrent thyroid cancer because for this kind of patient, maybe sometimes they have received neck dissection and they still encounter the recurrent or metastatic lesion. And most of the lesions are very small. If they receive surgery again, maybe it's very difficult for the surgeon, and also the patient will suffer from many complications. So in some guidelines, they also mention for this kind of recurrent thyroid cancer, if they refuse to receive or they cannot tolerate the surgery, maybe IFA or microwave is very good for this kind of patient. But recently, for this kind of topic, papillary microcarcinoma, some guidelines they just mention, but they don't have many suggestions. So in this issue, I think in the future, maybe PTMC is also kind of indication for the thermal aberration. But now, most of the guidelines just mentioned benign symptomatic thyroid nodule and the recurrent thyroid cancer. So let's begin with some benign symptomatic nodules. For this kind of situation, most of the thyroid nodule will cause cosmetic problem. We can see here, the patient have very obvious mass lesion here, and after operation, we can see it's obvious decrease the thyroid nodule. I think it's the same patient. You can see the nemus was here, but we can see the ultrasound experience. Before operation, you can see it's a very large thyroid nodule, isoechoic, and have some cystic portion. After performing several times IFA, you can see just very small nodule. I think I totally operate this nodule. It's just the residual thyroid nodule. And for this nodule, it's not very big, but here is the esophagus. The patient complain kind of dysphagia, compressive symptoms. So initially I recommend her just follow up, but the patient think the dysphagia may be due to this nodule, so I perform IFA for her. 1 month later, the result seems not very good, but 6 months later, about 1 year, you can see very small, the esophagus was here. So for this kind of patient, if they receive surgery, it's not very difficult for a surgeon because now the surgery for this kind of nodule is very easy for the doctor, but the patient have to receive lobotomy. Sometimes in very rare situation, even they just receive single lobotomy, they still have to encounter hypothyroidism. It's very difficult situation for the patient. But if we just perform IFA for them, it's very easy for us, and we can also help them solve their problem. Another patient, you can see the nodule is not very big, but it just above the trachea, and the patient have also very obvious cosmetic problem. So the patient did not like this situation, just request me to perform IFA, and 1 month later, 3 months later, and even 1 year later, you can see it's very, very small. So for this kind of benign symptomatic nodule, I think all of us can accept that thermal ablation, including IFA or microwave, is really very effective for this kind of patient. And we just use local anesthesia. It's just a OPD procedure. Usually for my patient, they just come to my outpatient clinics in the morning, and I will finish my procedure before 12 o'clock. So they still can have their lunch. It's very easy for us. And this kind of different situation, you can see the scar here. The patient have the papillary thyroid cancer with lymph node metastasis. So he received total net dissection, total thyroidectomy, and the radial net dissection. You can see the scar was here. So we can see the serial thyroglobulin change before operation, and then he received operation. After that, we can see for the biochemical complete response, usually after surgery and after radial iodine treatment, the thyroglobulin level should be less than 0.2, but you can see the thyroglobulin is not very good. We still can see the thyroglobulin level was above 2. It means there might be some small metastatic lymph node or some residual or recurrent lymph node. So I performed washout TG for this patient and found 2 small recurrent lymph node. But the patient have already received radial net dissection. The patient did not want to receive surgery again. So I performed IFA for him. So you can see I performed IFA for him. After that, you can see the thyroglobulin was less than 0.2. It means we can help the patient to have structure and the biochemical complete response. For some surgeons, I think we still perform surgery for this kind of situation. But for patients, they really don't want to receive surgery again because it's really very suffer experience for them. And we can see another cases. This is another recurrent lymph node just lateral to the internal jugular vein. You can see it's very close to the internal jugular vein. It looks very scary, but if you are good at the thermal ablation technique, we still can treat this very well. You can see after 6 months follow-up, it's almost complete disappearance. Even it's very close to the internal jugular vein, even close to CCA. I think it did not cause any problem to us. Sometimes we have to use hydrodissection or use very small electrode to treat this kind of situation. But usually the patient still can tolerate the whole procedure. And then we can see this different situation. It's also a recurrent lymph node, but you can see the size is about 1 centimeter. But here you can see, I think this nodule invade the trachea. You can see here, in this situation, we still can do. You can see that after that, the recurrent lesion was obvious decrease. So even the nodule invade, the recurrent lesion invade the trachea. If we can perform IFA very carefully, we still can treat them. I think I totally treat this lesion, and this is just some scar-like tissue. So in this situation, for benign symptomatic nodule and the recurrent lymph node, it's now if your technique is mature, it does not cause any problem for us. And then this is another case. You can see here, this is PTMC, and we perform hydrodissection here. Because usually we recommend use transisthmus approach, but for this nodule, I think the angle was too acute for me. So I give up transisthmus approach. I use lateral to medial approach. But in this situation, we have to be very carefully because recurrent angiograph is here. So if we don't perform hydrotaxation, it's not easy for us to complete treat this region. So I perform hydrotaxation. Here you can see I inject 5% glucose water, and we can separate the thyroid and the trachea. And now we perform IFA for the patient. And you can see I totally operate the whole nodule. The size was bigger than the original size because we recommend to operate the peripheral normal parenchyma to make sure we already operate the whole region. And we can see here before and after maybe, I forgot, maybe 6 months follow-up is almost total disappearance. So for this kind of PTMC, if the patient do not want to receive or they could not tolerate the operation, I think IFA or microwave is still very effective for them to treat the primary thyroid cancer. And this is another issue. You can see this is a primary parathyroid adenoma. For this kind of primary parathyroid adenoma, in the past, the patient usually received surgery. But now, because I think our technique is mature enough, so we can handle this kind of situation. You can see before treatment, after treatment, it's become very small. And we can see the IPTH level before treatment, after treatment, and I follow up for several months. The IPTH was still within the normal limit. So for the case sharing, I just share some I think the case was not very difficult because I'm not sure the audience, if all of the audience are good at thyroid IFA or microwave. So I just share some common case for all of us. As almost you later say in Thailand, they want to promote this procedure. I think if you are good enough, it won't cause any difficulty, but you still have some learning curve. So now we talk about the complication. I think no doctor like complication, but it's really very suffer for all of us. For this complication, we have to know how about the percentage our patient will encounter complication. It's really very bad situation for us, but we have to let our patient know the percentage, how often will the complication will happen. It's usually according to this meta-analysis for benign nodule, the complication rate was about 2.4%, but for recurrent, because recurrent cancer usually close to vagus nerve, usually close to some nerve structure or close to some vessel structure. So for recurrent lesion, the complication is much higher than benign thyroid nodule. So I usually recommend doctor in Taiwan, if they want to perform IFA, maybe they just perform first in the benign nodule. If they want to challenge themselves, they can try recurrent thyroid cancer, because according to many literature, they have mentioned that the complication rate to treat recurrent lesion is much higher than benign thyroid nodule. But if you are good at this procedure, the complication rate will be lower as 1%. It depends on how skillful we are to use the electrode to treat our patients. So at least we have to know how often will the complication will happen for the patient. So what kinds of complication we encounter during the whole procedure? According to radiology in 2012, there are kinds of complication, but we don't have to worry, because most of the complication will be reversible. I think for the most terrible complication will be voice change. I usually give lecture in Taiwan, so I usually like to show how the patient suffer from voice change during the IFA. Before the complication happen, the patient still can talk to you. Once the complication happen, the patient will immediately say, "Doctor, what's wrong with my voice?" Just like this situation, the patient will lose their voice just in front of us. It's really very scary for all of us, but we still can deal with this kind of situation. Later, I will share one of my very terrible situation, but I still can help the patient to recover their voice. But I hope all of us never see or never encounter this situation. So you can see this is my patient before operation, and I perform the IFA very smoothly, and then the patient come back. And then when the patient come back to my outpatient clinic about 1 month, the patient mentioned if she think the neck was swelling and the mark, the neck mass seems enlarged. You can see here, I perform ultrasound for her. You can see here is the fluid, and I put the color Doppler. Here we can see some color Doppler here. In each, it's my first case to my first this kind of complication case. Initially, I think maybe I have pseudoaneurysm. In some situation, the literature have told us pseudoaneurysm is one of the possible complications of RFA, because I see here, maybe in my mind, I think, oh my God, I encounter pseudoaneurysm, so I request CT for her. You can see, oh, it's not pseudoaneurysm, it's nodule rupture. It's really a nightmare for the doctor who perform RFA. So what should we do? I just request her to follow up 1 month, 2 months, 3 months, and then it's total obstruction by herself. You can see here, it's the end of the follow-up, but before treatment, you can see. So even a patient, even we encounter nodule rupture, we don't have to worry, but it takes time for patient to recover from this situation. Maybe we can prescribe some medication, for example, some steroid, because in some literature have mentioned that for this kind of nodule rupture, maybe due to some inflammation situation. So some literature recommend us prescribe some steroid, low dose steroid. But if you don't prescribe any medicine, it's okay. But the patient will suffer from neck swelling, and you can see this is another rupture case. This year I encountered this situation, but the patient totally recovered now. You can see here the skin will become erythritous change and some pus-like situation. And the follow-up, you can see here, it's recovered, and at the end, it's her previous OP scar. So you can see the skin will have obvious change, but you don't have to worry. Usually the patient can totally recover. But for this patient, it takes 4 months to have this result. So it's very suffering for us, but you don't have to worry. I usually tell Taiwan doctor, if you really encounter this situation, don't worry, just contact me, I can help you. And you can see here, I also perform MRI for her. You can see here, rupture in this situation, very terrible situation. But at the end, same situation, we have similar situation. This rupture material will just obstruction by the patient, so we don't have to worry. But we have to very cautiously not to cause infection. So sometimes I will also prescribe some antibiotics for this kind of patient. And then this is another nightmare, moist change during RFA. You can see here, this side vocal cord, just fixation. But after some treatment, you can see the vocal cord recover before the patient leave my procedure room. But it's really very suffer. You can see here, this vocal cord can move, but this vocal cord is fixed. It means the patient knows her voice during my RFA. It's another nightmare for the doctor. We can see what do I do to help her recover from her voice change. You can see it's the thyroid bay. I inject cold dextrose water, and after that, the patient recover from the voice change. Actually, the Professor Beck, my teacher, has already published a paper to use the how to management the nerve damage during RFA. You can see if you inject the cold dextrose water, you can see those who receive dextrose water injection usually can recover this kind of symptom immediately or during the injection of dextrose water. But if you really encounter this situation, I think most of us will be very nervous because the patient usually receive RFA or thermal ablation, just local anesthesia. So the patient will also very nervous. In this situation, we have to stay calm. Don't be nervous. So I just briefly introduce my first case of microwave experience, because this year in Taiwan we just have microwave. I really happy eco company can introduce their products to Taiwan. So I choose 17 gauge to 3.5 millimeter needle, and they recommend 30 watts. It's before and after 1 month follow. I think it's diffuse typhoid coil change. Personally, I think microwave is really very powerful because the procedure time is much shorter than IFA, and the patient did not have much complaint. Because in my mind, initially I think maybe microwave is too powerful for patient. Maybe patient will complain pain or any discomfort during the procedure. But during my first microwave procedure, I think it's quite okay or quite comfortable for my patient. So just let me make a short conclusion. I think thermal ablation for thyroid nodule is very effective, no matter for benign symptomatic nodule or recurrent PDMC or parathyroid nodule. And the complication usually will be temporary. We have to know how to manage this kind of situation. And for microwave, I think it's really powerful and it's very good for bigger nodule. So I think in the future, I still will choose some bigger nodule, and I will use microwave to treat this kind of patient. I hope my short presentation will help all of us know something about thermal ablation for thyroid. Thank you.